I would like to take this moment then to welcome Dr. Otugo to the stage and for her to say her opening remarks. So we're really excited to have her here all the way from Boston and representing a little university that many of us have never heard of. It's spelled Harvard. And I know some of you may not have heard of it, but it's a very reputable university is what I've heard. So I will now kick it over to her.
Great. Well, thank you for having me today. And thank you for that introduction. I'm going to just take the moment here to share my screen. All right, so today we're going to be discussing teachers as allies, standing by learners during race-related aggressions and microaggressions. So I wanted to take the time to go over some definitions in the first half of my presentation. So first, we're going to start off with microaggressions. So one of the key takeaways is that micro does not correlate with impacts. Just because the word micro is derivative of the word small does not mean the impact on the individual receiving the microaggression is something that's minute or very small to that individual. These can be as impactful as microaggressions and can be as long lasting. So initially, when people often experience microaggressions, there's usually a state of shock. And then usually hours, maybe days or months later, they're still perseverating about the issue that had happened and how they could have adequately responded to it. So these have long-term impacts on the individual receiving them. So microaggressions was first coined by Chester Pierce in 1970. It basically refers to subtle, stunning, often automatic and nonverbal exchanges, which are referred to as put downs. And as a result, they cause acts of biases, stereotypes, and prejudices, and they're all directed towards an individual. So these microaggressions are directed towards an individual's identity, whether it's their gender, their race, their age, and this is kind of where the isms come in, the sexism, racism, ableism, phobias such as xenophobia and homophobia as well. So an example of a microaggression, something that I constantly experience working on shift, is people often look at my name or they look at me or they think that they might hear an accent. They ask me where I'm from. So often I respond, I'm like, I'm from Maryland or I'm from the DC area. And they kind of look at me and they kind of pause. They're like, are you sure? And they're like, no, where are you really from? Because to them, someone who looks like me cannot be American. And to them, the stereotype of an American is often a white male. So because I don't fit into that box of what they believe an American is, I basically am not meeting their expectation. Oftentimes from that situation, sometimes I get, where did you go to medical school, to see whether or not I'm confident enough to actually be their doctor for the day. So macroaggressions are on a greater scale, kind of a systemic oppression of a marginalized group. These occur at a structural level and they encompass actions that are meant to exclude either through action or omission a particular group. And then another term that is something that you might come across is the term of homophily. So that's basically when someone or they kind of seek out another individual because they think that they share similar characteristics. So someone going up to someone like, hey, you kind of look like me, so we should have a lot in common. So that's another term that's actually kind of common, and especially in these micro and macroaggression spaces that we're talking about. And then imposter syndrome. So this is basically when an individual doubts their accomplishments and they live in fear because they're afraid of being discovered as a fraud. And these are basically the long-term impacts of being or experiencing micro and macroaggressions on a daily basis. And then next, what is racism? A lot of people have different meanings of what they think racism is, but I think it's nice to kind of come together on one commonly held definition. And this is kind of how I look at it. So racism is a combination of racial prejudice plus power. So often an individual in a place of power is enacting racist comments or forms of oppression on an individual that they believe is from a marginalized group. So you have to have power, I feel like, to actually be kind of considered something to be racist. So I kind of like this table here. Basically goes through the 4 levels of racism. This is a nice way to kind of think of things and ties together some of the concepts that we kind of briefly, or I talked about earlier. So macro level, we have the institutional and structural. So institution kind of refers to the hospitals that we work at, the medical schools, the nursing schools, the PA schools. And the structural is like the kind of think about it, the whole system. So we have the healthcare system, we have our cities, we have our states, we have our countries. And inside of those, we also have policies and laws that kind of are created, or they were created at some point to kind of keep certain people from climbing up a certain ladder, or basically keep people kind of continue to keep them marginalized in a particular area. And then on a macro level, we have internalized and interpersonal. So internalized, like I mentioned, microaggressions over time, you keep hearing the same things over and over and over again. And then this has long-term impacts on the person receiving it. And they become internalized. They dictate how the way they interact with another person, how they view themselves. This can lead to anxiety, imposter syndrome, depression. And interpersonal, we are people, we interact with the world, even if it's through Zoom. And a lot of these interactions that we have, like daily interactions, we might not even notice when there is a microaggression that we're experiencing, or how we might be making someone feel. So that's something else to kind of keep in mind. So there's this one particular study that basically looked at the letters, or the dean's letters received for medical students. And they basically looked at the type of language that was used for particular med students. So one study revealed that URIM applicants, which are basically in the States, these are often Latinx and people who identify as being Black. And they noticed that these applicants were 30% less likely to be described as exceptional compared to their white medical students in these spaces. In addition, the word competent was usually used as a negative association or negative connotation for URIM applicants, as opposed to white and Asian applicants at that time. And another thing is that there's another particular study that looked at the experiences of medical students with microaggressions. So first, they had to actually understand what a microaggression is to kind of begin with, but they noticed that white women were more likely, or women in general were more likely to kind of express that they had experienced some form of microaggression. And then about 68% of non-white women experienced some form of microaggression during their medical school training. In addition to that, they kind of also described that microaggressions were more common during the second and third year of medical school, and that usually correlates to the time when a lot of these medical students are on clinical rotations and are interacting with attendings and patients and residents. So kind of like bearing that in mind when we are working with our trainees about the different levels and different places where they might experience microaggressions. And then why do we care about whether or not our trainees are experiencing micro and macroaggressions? Because these can have long-term impacts. These can affect certain things, like whether or not they get into a particular honor society, like the AOA, for example. So only 3.5% of AOA recipients are URIMs. In addition, this can also affect how or whether or not someone can achieve or climb up the leadership ladder. For example, only 1% of clinical science department chairs in the States are Black women. But why do we need to address macro and microaggressions in the clinical setting? Well, it's because more or less, if we don't address them, we are failing our trainees as well as our patients in these spaces. And macro and microaggressions can lead to long-term impacts, like I mentioned earlier. So one of the things to kind of consider is the effects of anxiety, burnout, and imposter syndrome on our trainees. In addition, there's also the added diversity tax. So often individuals who belong to marginalized groups are expected to come into an institutions, lead their diversity initiatives, mentor all the other trainees that might look like them in these spaces. And then that's in addition to the current workload that they have. And because of that, they end up also being burnt out, and they're often not appropriately or adequately compensated for the work that they are doing in this space. And health. This impacts the health of our trainees, our physicians, but this also impacts the health of our patients. If we're in a system that has ingrained micro and macroaggressions, this has long-term impacts on how we also perceive our patients, what type of care they're receiving, the standardized testing criteria that were used for particular patients and whether or not they might get tested. For example, at Brigham, we noticed that some of our patients in the beginning of the pandemic, most of the people who were getting access to particular testing, they were from higher socioeconomic status. And this often meant that they weren't minorities to begin with. So like in the beginning of the pandemic, even though like we knew that, or we later found out that most of the people who were dying from the disease were Black and Latinx patients, they were not the ones who were initially getting tested. In addition to that, it can actually affect the trajectory into leadership roles or career advancement for our trainees. And then as a result, this has a filtering impact. So what is how being able to retain and recruit different minorities or having diverse faculty in terms of like fellows, med students, physicians, leadership, C-suite, like all this has a long-term filtering impacts. And over time, this basically leads to inequality. And not only that it leads to inequality, it leads to normalcy of inequality. Because people are so used to the status quo, people won't be willing to change it because they are so used to things being the way that they are. So what do we take from this? So one of the key things is remembering when we come into these spaces that we all have particular identities. And as a result of these identities, we may or might not have our own particular biases, and we do have our own privileges when we are coming into these spaces. So just being cognizant of our identities, how that affects how we interact with individuals, as well as our privileges and how this might impact how we may treat others in certain spaces and what other microaggressions they might experience. And kind of the caveat to that is kind of remembering our ability to advocate, especially when we are coming from a place of privilege, and being an upstander instead of a bystander. A bystander is someone that's passively watching something occur. They may come up to you and say like, oh, I'm sorry, that happened, that shouldn't have happened, even though they were in a position where they could have actually said something and made a change in that situation. And then remembering our role as kind of teachers overall, that like this doesn't only lie on a particular group, but we all have a role of educating and teaching each other that kind of prevents having these long-term impacts of macro and microaggressions on individuals. So now I guess we're going on to the case.
All right, well, thank you very much. I'm going to invite Dr. Azim, if you could take us through this case. Would you like me to screen share as well, Arden?
Sure, yeah, that'd be great.
Just so everyone knows, Dr. Arden Azim was, I believe, when you made this case up, you were still a med student at the time, right?
Yeah, I was in med school.
And so this was a case that we featured on an emergency medicine blog, but it really was a faculty development initiative called the Medical Education and Cases Series, where there were a bunch of different cases that we did. And by a bunch, I mean like 40 something, 48, I think, cases over 5 years, where we launched a difficult case into the world and then asked the world to discuss with us in a problem-based learning, but on a blog. And so we invited Arden to, at the time she was a med student, to present on this case. And so I thought she could maybe take us through the case, and then we're going to launch into, and I'll put the case itself into the blog, the link into the chat as well, so that we can take it, you can take it with you into your breakout rooms. But what I'll do is I'll have Arden present the case as if it was well, a case.
Right. So, hi everyone. So this case takes place on to your typical busy night in a ED in an academic hospital. Staff physician Dr. Young is working with a first-year emergency resident, Natasha, and a first-year off-service surgical resident named Stephen. For context on Natasha, she was born in India, so she's a woman of color. She immigrated at the age of 2. She's grown up, completed all of her schooling, including medical school in Toronto. Dr. Young's worked with her before. He's been impressed with her. She's competent. She has good bedside manner. Patients are happy with the care she provides. Now, a few hours into the shift, Natasha checks in with Dr. Young to review several of her patients and to find her next case for the evening. And Dr. Young finds a patient that meets Natasha's learning goals, which is to see a woman called Mrs. Richardson. Natasha's been wanting some more orthopedic exposure, and this woman has likely a wrist fracture from a fall that brought her into the ED, and specifically there may be an opportunity to do a procedure, so to do a nerve block and to reduce her wrist. So Dr. Young sends Natasha to see Mrs. Richardson. Mrs. Richardson is an older woman. She's white. She's been waiting for hours. She's clearly uncomfortable, cutting her wrist, probably a bit delayed in getting some pain medication. And Natasha starts the interview and notices that Mrs. Richardson seems frustrated. She's being dismissive of Natasha's questions, asking her to repeat herself multiple times. Like for so many patients, Natasha assumes behavior reflects the fact that she's in pain, that she's been waiting in the department for quite some time, and reassures her that once just a few more questions and she can have her get some pain medication and get a little more comfortable. But Mrs. Richardson is clearly looking more and more upset, and finally interrupts her and says, "Sorry, but I just can't understand what you're saying. Not to be rude, but can I get another doctor, a Canadian doctor?" Natasha's obviously caught off guard and tries to respond. says, I'm Canadian. I grew up here in the city. I've completed my schooling here. I'm sorry you're having trouble understanding me. Can I clarify something? Mrs. Richardson is frustrated and says, no, I don't want to talk to you anymore. I want a Canadian doctor, a white one that speaks English the way that I can understand. There's got to be one here. And Natasha stands in silence, staring at Mrs. Richardson, and just kind of leaves the room, saying quietly that she'll have her attending physician, Mr. Young, come see the patient. As Dr. Young is busy, he's juggling sick patients, but reassures Natasha he'll talk to her later, and then sends in Stephen instead to spare Natasha having to go back into the room. Stephen, of course, is everything Mrs. Richardson expects in a physician. He's tall, male, and he's Caucasian, and easily wins her over. She's pleasant, she's agreeable, and later on he reassures Natasha, saying, don't worry, she didn't say anything else racist or discriminatory. When I was seeing her, she was fine. Stephen gets to do the procedure. He does a nerve block, reduces her risk, and sends her home. Natasha continues on her shift. She sees other patients, but as the shift progresses, this encounter starts to weigh on her. She wonders, should she have said something different? Should she have confronted the patient? And also feels frustrated that because of her race, she did not get the chance to perform the procedure, and in fact, another resident did. Near the end of the shift, Dr. Young notices Natasha is visibly upset. She's less engaged in her patients, and he starts to question if he handled it correctly. He wonders, should he have said something to Mrs. Richardson? How would he approach something so uncomfortable and sensitive? Should he talk to Natasha or just kind of let the shift end? And he wonders, did she feel supported, and will this affect her future patient interactions?
All right, thank you so much for that. I'm going to stop screen share, and I am going to make sure everyone have you clicked the link in the chat, and you can all see the case as well. There are some guiding questions that come right after that we're hoping you can use in your breakout rooms to discuss. Hello, everyone. Well, we had an amazing breakout room session, but obviously for confidentiality and psychological safety, we did not record those. So instead, what we're going to do is have a digest of the speakers and the moderators and facilitators, and just have the four of us kind of recap some of our best take-home pearls that we wanted everyone to walk away with around the case that Arden presented. I'm going to ask Dr. Otugo to give it a shot first, because obviously she's the honorific guest. But what do you think are some key take-home points that people could walk away with and put into their toolkit?
Yeah, I think one of the key things is to kind of remembering to validate another individual's experience. Just because you might not think that something happened or something might have been misheard doesn't mean that the impact on the individual or the trainee was any lesser. So kind of just bearing that in mind, and then also kind of the ability to kind of create this environment of support around the individuals, like being able to advocate and being an upstander for them when these situations do occur.
And Arden, from your point of view as a senior trainee at this point, but obviously also the author of the case.
I think again, the key thing, you have to speak to these occurrences, and part of that, in some situations, that the most appropriate way to do that will be if the staff is in the room to the patient with the learner there, and it may be coming back to speak to the patient after and making clear that this is not appropriate behavior, but certainly naming what has happened, being clear about it, and giving the learner space to debrief, to process, however that looks like, both within the shift and afterwards, are all key to that culture of safety.
Mm-hmm. Excellent. And John, from your perspective, I mean, I think we wrestled with some of the tensions that existed. Was there one particular tension you thought that maybe we should all bear in mind when we're going forward and taking on this particular situation or a situation like it?
To me, one of the most difficult tensions in this case is, on the one hand, trying to support the trainees' autonomy in deciding how they want to go forward after facing this microaggression, which is a very serious microaggression. But on the other hand, making sure that the clinical and educational environment is safe for them. I think sorting that out really requires a good deal of insight into your own relationship with the trainee, how much trust there is in that relationship. There's lots of situations where support, providing autonomy could easily turn into coercion. And so I think in order to establish a supportive environment, I agree with Dr. Azim and Dr. Otugo, that you need to start with on your own, naming what has happened, calling it out, and not creating a culture of silence around microaggressions, and providing space and providing debriefing.
Yeah, I think that those are all really good take-home points. And what I was going to say is there is a wonderful article written in Medical Teacher that's called 12 Tips for Responding to Microaggressions and Overt Discrimination, when the patient offends the learner. It's by Wheeler et al. So Daniel Wheeler is the lead author, and they do go through quite a few of the things that we've just talked about, but they specifically kind of tease apart, exactly as you've just said, both Dr. Azim and Dr. Muniri, the idea that there's the in-the-moment response, which can look different ways depending on your rapport with and the seniority of the trainee and the tensions that are at bay at the time. But then I think it's about creating that space to acknowledge that it happened, coming back to it later on to make sure that the reflection can happen. I think it's about making sure that you create that space for the ongoing dialogue around kind of how to understand this for the learner, but then also being able to cycle back to the patient as well to understand their perspective at some point and see if we can move the mark and take on some of these, I think in my mind, inappropriate kind of gestures or microaggressions within the work environment to make our work environments a little bit better. But I do think that there are times when you have to know when to walk away, and that's like tip number 9 in the paper, and being able to figure out what it is. And I think that the best thing is to take some time to do that simulation in your brain, practice, just like you would whether it's what you're going to do at a critical resuscitation or whether it's in a critical situation like this, you're going to need to practice. So taking some time to think through what you would say, rehearse it in your mind. Mental rehearsal is just as important in any critical incident. And whether it's a code white, code blue, or, a situation where you have to intervene as in an anti-racist or anti-sexist way, I think is really important. So hopefully we can have those conversations and support each other in developing some of that. And I thank the 3 of you for being engaged with that. And hopefully people can take a look at some of those papers that I've suggested that are linked to within the website and are something that you can look up for your own learning and continued professional development. So thank you so much for all of you for engaging in this tonight. I really appreciate it.